Thank you. It's a pleasure to be here today and talk to you on pigmentary glaucoma. It's a relatively uncommon form of glaucoma in this part of the world, but it's a secondary open-angle glaucoma that results from pigment dispersion in the eye. So if you look at the prevalence of this disease, relatively uncommon, there are two forms. One is a pigment dispersion syndrome, which is more common, where you have pigment dispersion in the anterior segment, but you don't have glaucoma, and then the incidence of glaucoma is about 4 less than pigment dispersion syndrome itself. It predominantly affects the Caucasian population, and the clinical manifestation in people who have darker forms of irides is a little different, and we'll talk about that. It's often associated with myopia, but about 10 to 20% of these patients are emmetropic, and there's a group of patients who are hyperope, and this has been reported in middle-aged black women. The male and female sex prevalence is about the same. Males are more likely to develop pigmentary glaucoma, and it may also have a familial predisposition. So if you look at the pathological changes in pigmentary glaucoma, this is basically the trabecular meshwork that you're seeing here. The picture to the right is the one with pigmentary glaucoma, and you have pigment granules that deposit into the trabecular endothelial cells. And this pigment comes from the iris pigment epithelium rubbing against the zonules that release melanin and get phagocytosed by these trabecular endothelial cells. If you look at the trabecular meshwork by electron microscopy, I won't bore you with the details, but basically the findings that you see are very similar to what you see in open-angle glaucoma. The lower panel shows you pigment granules present in the trabecular endothelial cells affected by pigmentary glaucoma. What about symptoms? Most of these patients are asymptomatic, but an interesting finding that we see in these patients is that you have acute elevations of intraocular pressure with symptoms such as blurry vision, halos around eyes, headache, nausea, and vomiting, especially after intense exercise such as basketball, tennis, or soccer. I've had a few patients who, a glaucoma clinic in Chicago is on the 3rd floor, and this patient would walk up the stairs every time he came and would love to show all the residents and the fellows how pigment was dispersed in the anterior segment as a result of his exercise walking up the stairs. The clinical features, we'll talk about that, but I think for the young people in the audience, I would strongly encourage you to go and read this paper by Dr. Saul Sugar, published in 1949. It's the classic description of every possible aspect of clinical features of pigmentary glaucoma. So just to illustrate a case where it shows some of the clinical findings, here's a 29-year-old male with good vision, high unilateral intraocular pressure, and this patient's a myope. This is a patient from this part of the world. You see the darker colored irides. It's hard to see transillumination defects because of the thick iris. You don't usually see it. You can see the fine pigment on the anterior posterior surface of the cornea, better seen on a slit beam. You see the so-called Krukenberg spindle present in this eye. Gonioscopy is sort of a giveaway in this condition, and you see a number of findings. The first is the very densely pigmented trabecular meshwork band that you see up there. And the second important feature is you see that the iris surface is concave. So it's not normal, but it's concave. It's not like pupillary block. It's reverse type of pupillary block, where the pressure in the anterior chamber is higher than the posterior chamber, causing this iris to become more convex. And this is what causes the iris to rub against the zonules, releasing pigment into the anterior chamber and block the meshwork. Here's the UBM in this patient, where you see in the lower part, you can see how the iris is bowed posteriorly, which is very typical of this disease. Again, patient had a mild field defect, and you will see as I talk about the clinical course, typically these cases don't have severe glaucoma, unlike pseudoexfoliation, where the glaucoma progression can be pretty fast. Here are some other findings more in Caucasian patients where you have a lighter colored iris. You see the radial slit-like transillumination defects to the left. Again, a heavily pigmented meshwork by gonioscopy. And also, if you look carefully in many of the patients, and this is a sign you might see in people who have darker irides also on dilatation, you can see pigment behind the lens, of the crystalline lens as a stripe, so-called Shea stripe, and that's not an uncommon finding to see if you look carefully for it. The clinical course of this disease is rather slow. You can have these elevations of IOP. Most patients tend to do quite well. But this is one disease that burns out also. So you might see patients in their late 60s or 70s. You might see a transillumination defect here, a little pigment. The pressure's kind of normal, and they told you that they were on drops before, and now they're no longer taking medication. So this disease does rarely tend to burn out. You need to distinguish this from other conditions. Exfoliation glaucoma is one of them, where you see transillumination defects, but they're more at the pupillary margin. Angle recession glaucoma can release a lot of pigment, and the angle can get quite pigmented, and so as in uveitic glaucoma. Post-surgical changes can release pigment dispersion secondarily, as you see in the picture to your lower right, the lower panel where you see the haptic of the lens rubbing against the posterior surface of the iris, causing transillumination defects. Don't forget ocular tumors, especially in unilateral pigment dispersion. I've seen at least 2, maybe 3 patients with ciliary body melanocytomas or ciliary body melanomas and iris melanomas that presented like pigmentary glaucoma. One of them came to me filtered, and so and developed distant metastasis. Also, lower on the differential diagnosis is things like primary open-angle glaucoma and juvenile open-angle glaucoma. How do you manage these patients? Very much like open-angle glaucoma. For those of you old enough in this audience might remember something called pilooccusurge. This was an insert that contained pilocarpine and worked really well for these patients. You kind of stuck it under the lid, and it immobilized the pupil, preventing further pigment release, and also lowered the intraocular pressure. You don't have those anymore. Today, you can use pretty much any medication, and these medications, most of them work quite well in pigmentary glaucoma. What about mixed procedures? They can work well also, and so do trabeculectomies. I don't think I've ever done a tube in a patient with pigmentary glaucoma. Trabeculectomies do quite well in these patients. What about lasers? We'll talk about selective laser trabeculoplasty and also about YAG iridotomy and its role. So just like exfoliation, SLT or a laser trabeculoplasty of any kind work quite well, but you really need to use lower settings in these patients. I've had a patient in the past, a prominent radio personality in Chicago, who had SLT by a physician elsewhere. I ended up having to do a trab. He was mad at me because he couldn't wear his contact lenses after that, and I heard that over the radio. Yes. You can also do peripheral iridotomies. It's somewhat of a controversial issue. And the rationale for doing a peripheral iridotomy is that by doing it, you can reverse the pupillary block, whereas the iris, instead of becoming concave as it is, becomes flatter after you do that. Here is one patient who had iridotomy, and this is the same patient you saw with the concave iris, and after the iridotomy, the iris became more flat. Here's the UBM of the patient before, and here's the UBM after, the one below, showing you how the iris flattens out. This is well and good, but does it really work? So the point here is that iridotomy is somewhat controversial. There have been multiple clinical trials. I think the best time to do this is when they have maybe ocular hypertension, or you pick them up very early to prevent pigment dispersion. But once they have full-blown glaucoma, it's not of much use doing these iridotomies. So the prognosis in these patients is generally good. So in summary, we have a disease which is relatively uncommon, caused by posterior bowing of the iris that rubs against lens and zonules. There's a reverse pupillary block mechanisms. Typically, you look for this in young myopic males. And there are various treatment options, and they all work well in these patients. Thank you very much.
Thank you, Prof. Deepak. The next topic will be neovascular glaucoma, supposed to be given by Dr. Shawam, but for certain social reasons he couldn't make it. And kindly, as kindness, Dr. Deepak will give the topic. Please, Dr. Deepak.
Thank you, Dr. Bidan. So my next talk is on neovascular glaucoma, a condition I'm sure most of you in this audience are very familiar with. And I'm going to talk about, give you an overview, some of the clinical features, what testing we should order, some of the treatment principles, especially anti-VEGF agents, and some of my recommendations or pearls on how to manage this disease. So I'm not going to read this to you. For those of you who are old enough in this audience would recognize the voluminous volumes of Duke Elder describing lots of conditions. But he did not have a very good view about neovascular glaucoma and felt this was a gone case. Once you saw a patient like this, you either had to do retrobulbar alcohol injections, cyclodiathermy, or enucleate the eye when you had such patients. A very dismal outlook towards neovascular glaucoma in 1969. We've come a long way from that. So when you see a patient with neovascular glaucoma, you really need to understand the pathogenesis of the disease, where you have a number of ischemic proangiogenic factors that drive formation of new vessels in the retina, as well as on the iris surface, and those are all listed there. The main one is VEGF-A, which is an important factor, mainly produced by the retina and the ciliary body. When you look at the different causes of neovascular glaucoma, the prominent one is retinal ischemia, different causes listed on the left column. Don't forget that things like retinal detachment can also cause neovascular glaucoma, intraocular inflammation, various causes. Again, these are rare. And don't forget intraocular tumors, especially in patients. The one, if you see it in children, retinoblastoma is high in the list. And you will rarely see patients with these other disorders, and you have to sort of rule them out. Now, what are the clinical features? I think all of you are familiar with it, but I would like to point out to you that very early in the disease, and I've seen many patients of this, patients might present with just a red eye, something like uveitis-like picture with slight or normal IOP elevation. And so if you see a diabetic who is poorly controlled and older person with a first-time history of quote-unquote uveitis, keep this in mind, and within a few days they will present with very high pressures and full-blown neovascularization. So the pictures on the panel show you early vessels on the upper right column. Then you see more vessels in the pupillary border, which are common, followed by sometimes a hyphema, and then again after treatment or very long-standing glaucoma in the lower right panel, you see very mature blood vessels that develop on the surface of left untreated. Don't forget the angle in neovascular glaucoma. About 10% of patients will have no iris neovascularization. You'll have only vascular changes in the angle. You can see different findings. The upper left, the right panel shows you the final vessels crossing the scleral spur. Then you might see what looks almost like blood in Schlemm's canal, as shown in the picture to your left. This is actually vessels inside the trabecular meshwork. So the Japanese have shown very nice histopathological work that the vessels actually grow inside the angle, trabecular meshwork, and give you this blood in Schlemm's canal-like picture. All you might see is a microhyphema, which might be covering the neovascularization of the angle, as shown in the middle picture. And then shown as in the bottom picture, you might see a totally zipped angle if the disease is left untreated. So in the differential diagnosis of this disease, you have to think about uveitis, angle closure, chronic angle closure, retinal detachment, intraocular tumors, and post-RD repair. These are all different causes of angle closure, but it's very rare that you have to think about these other diseases, but often the issue is the cause of the neovascular glaucoma that can be at question and the treatment directed towards it. So the testing really, most of it is clinical examination. You might want to do a fluorescein angiogram to see for leakage. Don't forget if there's often these patients have a vitreous hemorrhage, so you need to do a B-scan to just make sure there's just not vitreous hemorrhage, but not a tumor lurking behind there. And in patients with ocular ischemic syndrome causing neovascular glaucoma, you can save a patient's life by doing a carotid Doppler examination. Systemic workup is sometimes needed, especially when the cause is in question and it's fairly focused because you kind of run down the list. This often is related to when you have tumors or ocular ischemic syndrome or systemic vasculitis. Depends on if you're thinking of those as a cause of neovascular glaucoma. Now, the principles of treating this disease are fairly, is something that should be understood. You need to treat the target source of ischemia driving the neovascularization, and in the meantime, while doing that, make sure that the intraocular pressure is controlled and that you don't have damage to the optic nerve. So you have to take care of various aspects of the disease to make sure that your outcome is good. So for the treatment, and when you have early detection with mild to moderate pressure rise, with no disc damage, sometimes just anti-VEGF agents followed by a PRP. Talk a little bit more about these in the next few slides. And glaucoma medications would be enough to control the disease, and very often the pressures come down. Now, once there is acute pressure elevation that is persistent despite treatment with PRP and anti-VEGF agents and glaucoma medications, surgery might be indicated, and we'll talk a little bit more about that later. And then when there's acute elevation of intraocular pressure, non-responsive for medications, a patient is in the ER, you can attempt anti-VEGF and PRP treatment and surgery. And I think the last category is what we see most often, especially in this region. So what are the limitations of PRP and anti-VEGF agents? So to understand how you want to follow your therapy, PRP is kind of the gold standard still. However, there are variable times for vessel regression. Takes about a month for 97% of these vessels to resolve. And it really is difficult to predict the response to PRP because there are so many variables. On the other hand, anti-VEGF agents can be injected either in the anterior chamber or more likely in the posterior, in the vitreous. The effect is short, but the results are dramatic, and the effect happens very soon, but the effect is temporary with one injection lasting about 4 to 6 weeks. So the current treatment, I think, followed by most are giving an anti-VEGF treatment and then supplemented by PRP. And then, if needed, you can treat them with aqueous drainage devices, vitrectomy with the pars plana implantation of a glaucoma drainage device, or, in severe cases, diode cyclophotocoagulation. Is there a role of trabeculectomy? The answer is yes. To do a trabeculectomy, you probably need to see all the vessels regress, everything quiet, and there's persistent pressure. They would work in those circumstances, but the failure rate can be variable, but you need to use mitomycin C for sure. So the current treatment, again, like I said, is a combination of anti-VEGF with PRP. Aqueous drainage devices tend to be the most commonly used. Vitrectomy with pars plana implantation, working with a retina surgeon, especially if there's a vitreous hemorrhage, and or traction detachments, and we talked about trabeculectomy and diode cyclophotocoagulation. So what about the timing of injection of the anti-VEGF before you do glaucoma surgery? There really is no consensus. The data we have are from vitrectomy surgery, suggesting that it's best to treat them 5 to 10 days before, then 1 to 2 days. There's one study where Ahmed valves were done. They were given intraoperatively. So you have timings, are they too long, too short, or is it just right? So we try to, in my practice, give it at least 1 to 2 days before. There's no consensus on the dosage. Most studies have used single dose, and most are intravitreal, and a few have used intracameral to treat these patients. So has the VEGF use improved outcomes in the treatment of neovascular glaucoma? So pre-surgically, it reduces iris neovascularization, reduces IOP, reduces PAS formation, may improve visual acuity, and delays the need for glaucoma surgery. You do need to do PRP in most of these patients. In those whom you're going to do surgery, I think the most benefit is from reducing the risk of hyphema, and it might improve outcomes of glaucoma surgery. There seemed to be a 3-fold increase chances of complete success in the study, which looked at the meta-analysis of the use of the Ahmed valve in glaucoma surgery. So we few years ago at KKISH looked at the use of how anti-VEGF use decreased the rate of neovascular glaucoma over a period of 10 years. And this is when bevacizumab or Avastin was available. You can see the arrow in 2008, and you can look at the rate of neovascular glaucoma that reduced remarkably after the use of VEGF in this very large hospital. Now, this is one place where you don't want to use mixed type of devices, so it's not very helpful. We already talked about trabeculectomies. Tubes do very well, and CPC, you resort for it as a last goal. So one of the issues with CPC is that if you do it in neovascular glaucoma, this is one area where you can cause hypotony in patients with neovascular glaucoma. So some recommendations, so when you see a patient with NVG, use VEGF if the media is not clear enough for PRP, or if there are other reasons for delaying PRP. So in all cases of NVG before PRP, there's some soft evidence suggesting it may prevent formation of PAS while the PRP kicks in early NVG. And I think it's useful to use anti-VEGFs when you do pre-op glaucoma before the glaucoma surgery, whether NVI or NVA is present or not. Be careful of Diamox in these patients because there are often renal issues in these diabetics, which is a common cause. For surgery, many patients are on anticoagulants. You got to be careful. When you're putting a valve in, lower the IOP slowly. It'll prevent you from the grief of having an intraoperative hyphema. This is one instance. I like to put viscoelastic in the chamber before putting a tube. Helps in preventing a hyphema. And make sure that the tube is not in the angle and you don't rub against the iris to cause a hyphema. Use post-op steroids generously and aquasuppressants if as needed. The prognosis is fairly good if you treat these patients early, and the vision loss typically is often retinal, not glaucoma, that causes vision loss in these patients. Thank you.